We're pleased to host an interview between Dr. Erica Spieth, who's a PhD Director of Clinical and Scientific Affairs and GTG in the US, and Associate Professor Charles Sayles, an Executive Director and Founder of Sayles Health. So if I can pass over to you, Erica, and thanks for you and Charles for joining us this morning.
Great, thank you, Adrian. So Charles, thanks for joining us today. I know you hold a few different positions as a specialist senior consultant at the Mercy Hospital for Women in Melbourne, and you're also the founder and medical director of Sayles Health, also in Melbourne. Can you tell us a little bit about your practice and your vision for preventative health that fits within obstetrics and gynecology?
Yes, thank you, and hi everyone. I'm privileged to be here to be with such wonderful people. Look, Sayles Health is basically a medical service which is started as an imaging company looking at women's health, because I'm also an ultrasound specialist, but it sort of evolved into a more medical consultancy service where we provide imaging and screening and management of patients as a total package. In order to start this preventative program, we need to go into more systems of scoring and working out whether we can target prevention rather than a generalized prevention program. And this is where this GeneType comes in beautifully, because we've added this to our suite now, service availability, so that we're looking at the polygenic risk scoring system. And with that, and I'll go through in more detail further later on, but certainly it's the best way to change the paradigm where it's always been about treatment. It's been about generalized prevention programs, which is funded by government. And then screening comes at the bottom of the current way we do things at the moment, which just seems to be climbing up, but not really taken on very seriously. We want to flip it, completely flip it on its head. And so our concept of prevention is raising the concept where we have a screening at the top of healthcare. We've got targeted prevention as the way forward rather than generalized prevention. And that leads to a concept where we've got imaging or testing for early detection. And therefore that leads to minimizing treatment. So we want to flip the whole thing upside down. And that we find that's probably going to become the best model of care for efficiency and cost outcome and individualized care.
In the current healthcare system, do you see any shortcomings and how a test like GeneType may help close the gap?
Yeah, and I think it's so. And I think the shortcomings are sort of based upon the things that are changing rather than looking at them as shortcomings. I think they're appropriate for the time, but it's now appropriate that we move on. In healthcare, we've moved on from a very rudimentary form of screening to a very sophisticated screening, where basically with the NIPS detecting for Down syndrome now, we pick up 99.9% of Down syndrome. That was unheard of before in the limited fashion they had before. But I think this is evolving, and it needs to evolve through a screening process that I've just described in order to maximise the personalised care of medicine and to minimise the healthcare costs for the community and also for the individual.
Thanks. So I know you've mentioned this briefly in a previous statement in terms of very simplistic factors, but before GeneType, what kind of risk assessments have you traditionally used in your practice?
Generally, as it currently stands with this concept of screening, it's poorly formed, and we sort of do it ad hoc on a clinical fashion, such as, yes, we do take a history and we take a family history, and there's a screening process. We do, is there a strong genetic component of some disease in some family? We take it into account. We also use symptoms and signs or what the patient presents with. And so this is a very democratic way of actually doing healthcare, where suddenly we've got a risk scoring assessment that looks at the three major factors of the health issues. For example, in breast cancer, it's the familial history, there's the imaging component looking at breast density from mammography and the polygenic side of things to develop a score. And a score is a powerful tool and a simple tool in order for patients to feel they own their space, but quickly reproducible, easy to find management pathways, and easy to record data and to analyse outcomes.
That's great. And based on what you just said, how does this fit into your current patient management approach and your overall vision?
If we find a high-risk case, then we've got to look after them. And therefore, in order to provide a screening program, it's not just providing a test, but it's the test and the counselling that I've said, and the pathway management of the high-risk case. And with that, it lends itself to do directive, as I said before, targeted prevention, early detection, such as more frequent or appropriate testings, such as MRI or imaging or blood tests, and therefore to minimise the need to do any further referrals to subspecialists to do surgery or further tests or further management, to minimise that pathway because we pick things up early. Ovarian cancer is actually 100% curable if it's picked up really, really early. But sadly, they present very late, and it's a very poor prognostic outcome because they present with stage 4 disease. So the pathway here is the vision, which we have a score for any one of those pathologies or diseases that we're investigating, is to have a medical service, a concierge service that allocates like a case study for a patient to be looked after and guided through their journey of care to minimise treatment outcomes in the end.
And in breast cancer specifically, I know there are general population screening guidelines and there are high-risk screening guidelines. Are they well utilized? Are there any shortcomings? Are there any improvements that could be made in the current healthcare system?
Yeah, well, look, if I equate it through my experience and my journey through pregnancy screening, it's like, if you look at back in the late 80s and early 90s, we used family history for Down syndrome screening. Is there a family history? We tested them if the age was the other factor. So we created a paradigm where it was family history and age. And that was picked up 35% of Down syndromes. And then with Kypros' Nicolaides' sort of vision and development of MIPS subsequently, we now pick up 99.9% of Down syndromes because we've evolved into a further stratified screening program. If you equate that to this system that we have now, for example, in breast cancer, it's no coincidence we use family history and we use age. And in Australia, with family history, you're looking at the first degree relative, and then if it's positive, then you do a BRCA test, and if it's BRCA positive, then you've got a greater than 50% chance of developing breast cancer in your lifespan. The problem is that's only roughly 5% of all the breast cancers, and 95% are all BRCA negative. So a lot of people who have BRCA negative tests sometimes can get falsely reassured. In fact, sometimes it's detrimental because they actually get reassured they've got a negative BRCA test. I am now safe, which is not an appropriate thing to happen. So the other thing that we use is age. We provide a sort of a government-funded mammography service every 2 years from the age of 50 to 74, and that looks for lesions. It's not a total screening in a sense. It's sort of called screening, but it looks for cancer. And the problem with that is that the uptake for screening, if you call that screening, just using age alone, basically the uptake for the first mammogram is roughly 90, 95% plus. But then for the second one, 2 years later, it drops down significantly. And for the third time, probably less than 50%. And the reason is every time they have a negative result, they get reassured they don't need to do it anymore. And they're not counselled or informed significantly as a process that they're still at risk. And so these people are lost to the system. So subsequently, with the development of the risk scoring in Down syndrome, the gene type is now evolving in a similar fashion, where we've got the major risk factors such as family history, breast density, which is really important, and the polygenic assessment to develop, as I said before, a score. You actually then feel that you have that risk with you and you want to do the best to minimise it or reduce it.
Dr. Stiles, thank you so much. I'm going to leave you with one last question. What is next for you and GeneType and the overall patient care program that you envision?
I can see the future because I can see how obstetrics has evolved. And therefore, the natural progression from treatment model to screening model has to come forward. And it will come forward. And therefore, we need something like GeneType in order to do it. And what gives me comfort, GeneType, is that it's been scientifically compared to a lot of other screening tests. And I think it's come equal or better than any other test on the market. So I think it's at the forefront of its technology. And therefore, using that, with that comfort, I can move forward and incorporate it within my medical suite of concierge assessment program